Hello, everyone. My name's Holly Mathias, and I'm a PhD student in the School of Public Health at the University of Alberta in Edmonton, Alberta, Canada. And today I'll be presenting on a synthesis of global research that outlines family caregiving for people who use drugs in rural settings, including what we know and next steps. First, I'd like to acknowledge that the work that I do takes place on Treaty 6 territory, which is the traditional lands of the First Nations and Métis people. I also acknowledge the nearly 35,000 Canadians and many more from around the world who have died from a toxic drug supply, and the many more families in the communities who are grieving their loss. Before beginning, I want to take a moment to offer insight into how I position myself in relation to this topic. As a public health PhD student and an ally of people who use drugs and their families, I take a public health and a health equity approach to thinking about this topic. In other words, I think about the many different layers of our society, structures, policies, individual and community level factors that influence the need for caregiving, as well as the experiences of caregivers. And being born and raised in rural Canada, this beach photo was taken this fall while visiting my family. And as someone who became a young caregiver for my dad with chronic health issues at the age of 24, these experiences have driven me and they motivate me to do this work. Canada is experiencing a drug poisoning crisis. Between January 2016 and September 2022, there were nearly 35,000 drug-related deaths in Canada. And this map on the slide shows numbers and the drug deaths from 2022. And the darker the purple is on the map, the more deaths that were experienced. And this is a death rate, I should add. These deaths have been linked to a toxic drug supply, which has been intensifying since the onset of the COVID-19 pandemic, as well as harmful drug policies. And there are other additional harms also linked to substance use, including but not limited to the rise of HIV and hepatitis C, precarious housing, and risk of arrest. Access to a range of health and social supports and services, such as harm reduction, treatment, and safe supply programs, may help reduce some of these harms. But in some rural places, there are specific challenges to access, including a lack of availability of services in some communities, stigma and discrimination linked to the size of the community and perhaps lack of privacy, and criminalization and risk of arrest. In many cases, informal supports will fill these access gaps when access to formal supports and services don't exist. And to give you a sense about what rural looks like in Canada, it's defined as communities of under 10,000 people. And this map highlights in gray all of the land area that is considered to be rural. What is highlighted in green is considered to be an urban area in Canada. And so although a lot of people do live in urban centers in Canada, geographically, we are a predominantly rural country, and substance use is not just an urban issue. There are many people who are using substances in these gray rural areas. An important informal support are family caregivers, and these are family members who do not receive financial compensation for caring for an individual, yet they provide around 80% of informal unpaid support in Canada. And it's estimated that around 25% of Canadians will be a family caregiver in their lifetime. Now, most of our knowledge on family caregiving is linked to aging. Not much is known about family caregiving for people who use drugs, especially in rural places, and what we do know focuses on peer support and youth substance use. So I wanted to know who provides family caregiving for people who use drugs in rural places, what activities comprise their care work, and what is the impact of performing this care work for these family caregivers. And to answer these questions, I decided to conduct a narrative literature review, and this took place between September 2021 and January 2023. I searched scholarly databases, hand-searched relevant journals, and also scanned all references of included articles. I included articles that were peer-reviewed manuscripts published in English between 2016 and 2023 in order to try to gather information about caregiving in the context of the drug poisoning crisis. And I focused on articles about unpaid family caregiving for adult people who use drugs in rural places. There were no geographical limitations to this search, so I did look at articles published globally. In total, there were 9 articles that I found, but 6 were excluded because although they may have recruited rural and urban family members, they didn't do a place-based analysis. So they didn't actually talk about the role of living rurally. So in total, only 3 articles met my criteria. These articles were from the United States and India, so none from Canada or from the Netherlands or other European countries. And they centered on middle-class white families and the impacts of caregiving. So we still don't know a lot based on this in terms of what type of work is being done or maybe who is doing the work. And so here are a couple of takeaways from what I've been reading. First, I found that unsurprisingly, caregiving is gendered. Most family members providing care in rural places are mothers and wives, and there may be a few reasons for this. Aside from Engstrom's loving care theory and caregiving, where someone is providing care because they love their family member, there are many social expectations of gendered roles in the family. And so for mothers, for example, especially in North America, there is the value of intensive mothering. And this value is quite common in the United States, where it's assumed that all time, energy, and resources of the mother must be dedicated to the child. Otherwise, they are a bad mother. So there may be times when mothers feel like they might have to care for their child, not just out of love, but because society expects them to. And there's this constant pressure about what looks like a good mother and what looks like a bad mother. Wives, and this was particularly in the literature from India, may provide care to their spouses because of cultural norms and responsibility, but also because of fear of stigma and lack of privacy if they reach outside of the household for support. So again, this concept that substance use is a very private topic and that it's something that remains within the household. In terms of caregiving activities, I sum it up by saying that caregiving is done in the context of crime. And what I mean by that is that a lot of the activities and care work that people do is similar to caregiving for other health issues. So family caregivers are supporting access to health and social services, such as transportation, maybe co-paying for treatment, and supporting the general well-being of people who are using drugs. But their work is framed within the context of criminalization and subsequent stigma. So for example, some people are the sole caregiver for their person who's using drugs because perhaps that person's spouse or themselves are incarcerated or in treatment. And so a lot of what is being done is framed within the context of crime and stigma, which might not be found for other health issues. And finally, caregiving for people who use drugs is very challenging, and it can be challenging. There are many impacts that are named on both the caregiver themselves and their relationship with others. So for example, because of there may be increased financial challenges due to legal system and treatment costs. And because substance use is so stigmatized and discriminated and criminalized, there can be social and isolation from other support systems in the community, like other friends or community groups. And I think it's most important to note that there are very, very few caregiving supports available for caregivers of people who use drugs, particularly in rural and remote areas. Particularly in the context of Canada, we know that there is no national caregiving strategy or framework, and it's considered to be the next frontier of public policy. But while we wait for these policies to be put in place, many caregivers are struggling without those supports. So in summary, a few key takeaway points that I hope you get from this presentation is that family caregivers are very important supports for people who use drugs in rural places. However, their work is tied to the criminalization of drugs, which can make it a lot harder for them to do this work. And because of that, there can be real impacts on themselves and on their relationships with others. There are also very few supports for family caregivers of people who use drugs. And there needs to be a better understanding of diverse experiences, including the experiences of other family members, like fathers, siblings, and extended family members, the experiences of Black, Indigenous, and people of color, and experiences in rural and remote settings. So what's next? What's next for me is that this scan has really set up what I will be doing for my doctoral research. And my doctoral research will be a qualitative community-based study looking at family caregiving experiences in the rural communities in the western provinces of Alberta, Manitoba, and Saskatchewan. And these are 3 Canadian provinces. This work will include semi-structured qualitative interviews with around 60 family caregivers and people who use drugs in rural Canadian communities. And it will ask them about their experiences, including the work that they do, the impact of that work on themselves, as well as what supports are needed for both themselves and their loved one who is using drugs in rural Canada. This work is being developed with several community partners, including members of Moms Stop the Harm, Manitoba Harm Reduction Network, the Alberta Alliance, who educate and advocate responsibly, and many academics from these 3 provinces. And ultimately, the aim is to bring visibility to rural substance use, outline requisite supports for people who use drugs in their families in rural places, and inform advocacy efforts. So in closing, I just want to thank you for listening to this presentation. I'd also like to offer special thanks to the members of the research team who are helping shape my doctoral research, including my supervisor, Dr. Elaine Hishka, and also a special thank you to funders for my work, including the University of Alberta and the Vanier Canada Graduate Scholarship. If you have any questions about my work, this presentation, or like some more information about what research I'll be doing in the future in rural places, please feel free to reach out to me. My email is listed on this slide. Thank you.